over to our presenter this morning.
All right. Good morning, everyone. Again, my name is Sonori Ersprung, and I'm from the Department of Public Health. So today we're going to go over a number of different broad concepts around data, how to use it. So just to give you an overview of kind of the way we've structured today's presentation, we will be talking a little bit about some of the situations and products for which you might need data, or kind of why we might want to use data at all. We'll talk a little bit about some of the types of data that we might want to consider using at different phases of your program, implementation, so on and so forth. We'll also then talk a little bit about some of the different types of data that exist, data sources specifically, and we'll review some of the aspects of data sources that we may want to consider as we're deciding which data source to use or which indicators to use. And then finally, I'll do a demo. We'll have some resources that we'll also send out to you as to some actual links to specific data sources and data inventories, but I'll do a demo showing you kind of how to navigate a few of those to give you kind of a feel for how to apply some of the information we learned earlier in the webinar to actually accessing the data in real time. And between each of these sections, I'm going to pause for questions. So if you have an immediate clarifying question, you can go ahead and type it in the box or raise your hand. But if you have a kind of deeper question on any of these content areas, we can cover it during those little question breaks throughout. All right. So before we get started, I wanted to get a feel for, of the folks who are participating today, what your comfort level with using data is, so that I can kind of tailor some of the things we talk about today to your comfort level. So on one side, we have a scale of 1 to 5, with 5 being I regularly analyze data, I'm familiar with statistical software, so you're very, very comfortable. And on the other side, on the 1 to 5 scale, we have data scares me. So from a scale of 1 to 5, we're going to do a quick poll right now to see where you guys fall.
Awesome. So the poll should be on your screen now. Feel free to jot in your answers there when you all are ready. And the answers are coming in. Thank you so much. But keep answering. We'll give you a couple more seconds and then we'll close the poll. Maybe a couple more seconds. All right, so we're going to close the poll now and show what people came up with.
All right, so it looks like a lot of you are right there in the middle, somewhat comfortable with data, but there's actually a number of folks in the audience who really deal with it on a regular basis, so that's great too. So throughout, I'm going to go ahead and define some of the phrases and terms that we use. So I apologize if there are things you're already familiar with, but I want everyone to be on the same page. All right, so let's attack objective number 1. Why do we need data? So all of you come from a broad range of different types of programs and institutions, so you use data for a lot of different reasons. Writing grants, justifying the need for a grant, making presentations to stakeholders, doing health impact assessments, creating community health improvement plans or needs assessments, doing looking at resource allocation from a data-driven approach, so really using information and data to inform how you allocate limited resources, doing quality improvement or quality assessment. We abbreviate that with QI or QA, making presentations to funders, and program evaluation. And this last one, program evaluation, is a particularly significant use of data that a lot of you expressed an interest in when you were registering for the webinar. And there's a lot of different aspects to data that goes into that. So before we even start planning an evaluation or implementing a program, there's 4 questions that when we sit down with our program staff, we always ask them just to help them start thinking about how to concretely think about different aspects of their program before we even start rolling everything out. So those questions include, why do we even need our program? Or do we even need our program? So is there a gap? Is there unfilled, unaddressed burden in our community or in our organization that we're trying to fill? And what data can we think about to try and justify that and contextualize that? Second question is, what will our program change? Now, obviously, you don't have a crystal ball, so you won't know everything, but before you even start implementing an intervention or a program, you always want to think and predict, in the long run, what do we think that it's going to impact, as well as in the short and intermediate term, what is it going to impact? That helps us start at baseline itself, in the planning phase itself, start thinking about what kinds of indicators and data elements we want to start capturing. How will the change occur? This is a really a processy question. So who's going to be at the table? What stakeholders are involved? What are some potential barriers we want to keep track of to make sure that we're implementing it in the most efficient way possible? And finally, how will we know if we've succeeded? So yes, we want to change all these amazing long-term outcomes, but when at the end of our 5-year or 2-year period of time, when we go to our stakeholders, what kind of metrics and concrete factors do we want to go to them to say, see, it worked like we thought it would? So these questions are things that address and should be thought about both at the planning phase as well as throughout your program lifespan. And every program has a number of different phases. I think different entities, different schools of thought kind of slice and dice different phases of a program differently, but I'm using this kind of progression from the CDC, which breaks up a program into a planning phase, an implementation phase, an assessment phase, which is just immediately after the program is being implemented, and then a long-term impact phase. And the data that you would want to consider, or the indicators, that's a very specific metric that you would capture, that you may want to be measuring and tracking throughout, vary also by these phases. So for example, in the planning phase, you want to really focus on data that establish whether or not there's a need in your community, whether or not your program has capacity. Does it have the money, the resources, the staff time to actually implement a program? And also, is it feasible? Is there political will? Is there access? So those are the kinds of metrics that you may want to capture or incorporate into your work plans at that planning phase. As you move on into program implementation, the types of data might be a little different that you want to focus on. So you really want to track how well your program's rolling out. You may want to look at cost effectiveness. You may want to look at what kind of stakeholders are at the table. You may want to look at what barriers you're facing so that you don't get 5 years down the road and realize there was a very simple barrier you could have addressed right in the middle to make your program more impactful. As you move along, when you head into outcomes phase, you want to track some of the short and intermediate changes that are resulting from your work. You know, the main purpose of your program, is it accomplishing those goals? And in the long run, even beyond that immediate outcome, you may want to look at some broader impacts, even beyond those immediate changes that you expected from your program. So that could include long-term changes that impact your participants' lives on a much broader scale. Things like property values going up, or people's awareness going up, or long-term disease rates. So we talk about these kinds of indicators in different phrases. So just to give you some familiarity with some of the lingo that evaluators use, a lot of times people refer to that early phase as a needs assessment phase. So if you hear that, that's often what they're referring to. And a lot of people refer the metrics that you capture in all those subsequent phases as performance measures. So you'll hear me refer to those kinds of specific metrics as metrics, indicators, or performance measures. They are often talking about similar types of data that you capture, but different audiences maybe would use different phrases to describe what it is. All right, so let's talk about some examples of some very specific metrics or indicators or performance measures for a very specific example. So say you're a program who is aiming to roll out a matching program in your region. So you want to establish some more farmers markets, and you want to make sure that they all provide SNAP and WIC benefits and matching at these farmers markets. So in the needs assessment phase, you want to think about, okay, does my region need a SNAP WIC matching program, and does it need more farmers markets? But also you want to think about how many people might you reach, right? So how many SNAP and WIC eligible persons are even in your region? If there's only 5 or 6 people who really want to roll out a whole program. How many residents in that region live in a food desert? So if you establish even one farmer's market, might you increase the access for thousands of people by establishing that? So that's kind of the needs assessment phase. Just a few examples. There's plenty more you could capture in that phase. As you move on to implementation, some of the indicators you might be interested in capturing could be things like what sectors and partners have we engaged? Did we reach out to the municipality? Did we reach out to local food trucks? Are businesses on board? Are there sectors that we didn't even think about that we accidentally left out of this engagement process? Some other indicators could be things like barriers and facilitators. For example, barriers and facilitators to implementing the machines themselves. It could be, once you do that kind of an evaluation, that you find out that awareness isn't a problem, setting up the markets isn't a problem, but getting the machines has been the biggest barrier. So if you can get a new partner to the table, you could speed up that part of your program implementation really effectively. Now, after you've rolled out this program, you've established the need, you've kind of tracked how it's being implemented, then you get to the outcomes phase. So this is where you really try and capture the things that you expect your program most directly, most immediately will improve. So indicators or performance measures could include things like the number of increased SNAP and WIC matches redeemed. You know, how many dollars are people actually receiving from this program? Or the increase in the number of farmers market customers. Are we driving business? Are we bringing people in? Are we engaging the folks the way we thought we would? So these are very measurable, specific indicators or performance measures that you could add into a work plan, into a grant proposal, or just into your own operations process to really track how your program is doing, and in very concrete, measurable ways. And as we move into the longer term impact phase, there are a number of metrics that you might want to capture. So in the long run, has there been an increased purchase of fruits and vegetables in your region? Not just amongst those in just the data that you're capturing at the farmer's market, but just in that whole area. Are the number of residents, are there an increased number of residents now with improved access to healthy foods? So from kind of a mapping perspective, literally how many people are living in the area who are being impacted positively by your work. And then even longer term, are disease rates going down? You know, are people engaging in more healthy behaviors? So these are things that sometimes maybe even years out in your in terms of impacts that your program has, but if you're in it for the long haul and you're around for a long time, these are things that you can look at over longer periods of time. All right, so we've talked a little bit about kind of some of the scenarios in which we might want to use data. We've talked a little bit about the types of indicators and types of data we may want to consider at different phases of monitoring and evaluation. We will go over some more specifics around data sources shortly, but before we move on to that, I was just wondering if there were any questions that people had regarding that kind of thinking about your program in multiple stages. So if you have a question, you can go ahead and type it into the box. And Daisy, have we had a few come in yet?
No, not as of yet, but feel free to text any. I know the data world can seem a little overwhelming, and so far I think it's very digestible. But if you all have any initial questions or thoughts, feel free to type those in.
Yeah, and if not, we can certainly save them for the end or cover them later on. So now that we've covered some of the scenarios in which we may want to consider different types of data at different phases, let's talk a little bit about the kinds of data that are out there. Now, I work for the Department of Public Health, so we focus a lot on health outcomes, and all of you are at the Community Health Institute webinar, so we all care about health, and we know that there's a lot of factors that impact whether someone is in good health, has access to the kinds of resources that help them live that way. So some classes of these determinants, these things that impact your health, include things like access to clinical care. That covers a broad range of types of data, things like, you know, are there enough doctors for the number of patients who want them? How many primary care visits are people engaging in? Is there insurance coverage available for folks? But there's also data that we're interested in around health outcomes. So not only can you access health care, but how are you doing in terms of your actual health? So disease rates, how many hospitalizations or ER visits people have in your community. There's also another whole class of indicators called around health behaviors. So not just do you have diabetes, but what about all the things that impact whether or not you have diabetes? What are the behavioral aspects that might be relevant? That includes things like health behaviors around diet, exercise, but it also includes things like getting vaccinations and as recommended, accessing and getting cancer screenings in the appropriate times. So that's a whole class of indicators that that's out there around health. There's also a lot of other factors that impact your health and that you want to capture when talking about health, including demographic information, information around community. So are you engaged? Are folks safe in the community environment? And also indicators around the physical environment. So this could include things like housing, access to transit, the kind of infrastructure, built environment infrastructure they have around them, such as access to healthy food retail locations. It also includes things like environmental contaminants, so air particulate matter, how close you live to a highway. So those kinds of factors also impact people's health pretty significantly. So because this is a health info webinar, I'm going to focus a little bit on some of the health data sources. So that covers the three areas we just talked about: health behaviors, health outcomes, and access to clinical care. So these kinds of data sources are available from a number of different places and different types of sources. So all those indicators could come from any number of different sources, including health surveys, disease and injury registries, clinical data, so that's data that comes straight from a hospital or clinic, such as electronic medical records or claims data or hospital discharge data from the ER. It includes count or census data, so that's data where every single individual in a certain population is included in that data set, such as birth data, so like every single person who's born has a birth certificate, so we know that they're all included in that. And then I'll also go over a few other data sources that might be appropriate for your particular situation, especially things that might be local sources of information that vary across the state. So now I'm going to go over each of these in a little bit more detail and give you some examples of the types of sources that exist for each. But first, I'm going to go over some of the aspects or qualities of data that you may want to consider when picking between a health survey versus clinical data or some other contrast.
Looks like we have a question.
Sure, yeah, let's take a minute.
And you can decide if you want, if it will be addressed later or now, but we have a question here about how will the PWTF data,
the Prevention and Wellness Trust Fund.
Thank you. Yeah. We're now collecting help us determine the long-term outcomes. What was the thinking about a short-term set of interventions having a long-term impact that could be measured many years down the road?
Sure. Well, I'm just wondering whether to take a breather right now or maybe whether to talk about that. Well, we can talk about that now. So the way we think about health outcomes is shifting. We have, I think, the way the public health field has started to focus on people's wellness is in a much longer term way, and I think part of that comes from cost containment, because we're realizing that the biggest drain on our healthcare system is a core set of chronic diseases. So we're seeing, back in the day before health care access became much better, some of the biggest killers were things like heart attacks and strokes. Stroke still is pretty high, but now we're seeing more and more deaths from things like diabetes, obesity-related illnesses, hypertension, things like that. So those types of conditions are now some of the most burdensome health indicators or health issues facing us. So the PWTF was really created to impact those long-term outcomes. But as you know, we don't become obese overnight. We don't get diabetes overnight. There are factors in our life, from access to healthy food as a child all the way through our life choices as an adult, that really impact whether or not we're at risk for those conditions. So that while the PWTF is collecting those really long-term outcomes, we don't expect some of the interventions that we're doing just in a couple years to reverse the trend of some of these really, really long-term outcomes overnight. So we want to make sure that some of these short-term outcomes are included so that we can look at things that in the literature have been, through evidence, shown to ultimately lead to those long-term outcomes. So that's why some of the short-term outcomes that the PWTF tracks, things like access to health care, number of individuals entering lifestyle change programs, or things like asthma home visits, how many people are registering for those, how many people in the EMR data are actually getting accurate diagnoses, how many people are now controlling their blood pressure. So it's great. Like if you see now an additional certain percent of individuals who are in control of their blood pressure, they've become diagnosed, they've been given meds, they've been taught how better to make some lifestyle changes to control their disease. Those are some great short-term indicators that show that your program's really making progress, even though you may not see hypertension rates go down for a number of years in the future. So that's the rationale, the thinking about setting short-term indicators and interventions that have a long-term impact. We will continue to track those long-term outcomes, but as with any program, that's a great example of how you want to really structure your indicators to show progress to the folks that have the most interest in whether your program's working in the short term. If we had only included lowered rates of hypertension, asthma, falls as our indicator, then it might not have shown as much progress in the short term. So we can talk a little bit more about some really concrete examples like that further down the road, and certainly if my answer didn't cover all the things you were interested in, maybe we could really talk about that a little bit more at the very end when we have some really great discussion. But excellent question. All right, just as a quick reminder to get us back set on what we were just talking about, some of the data sources that exist for health data include things like health surveys, disease registries, clinical data, count or sense data, and then we'll cover a few others. But when picking between each of these and weighing them and comparing them, there's some certain aspects of data that can be helpful. Now, these are not going to be exhaustive. You could get a whole degree in this just talking about how to compare and contrast different data sets, but I'm just going to give you some of the most common ones that our partners talk to us about and ask us about so that you can start framing out what makes different data sources different. So one aspect of data that you may want to consider is geography. So geography covers a few different content areas. One is what we call granularity. So is the data source that you're interested in available at only a state level, or is it available at a county level or a town level? Or if you're a clinic and you're doing an intervention just with your patients in your clinic, do you want actually something even more granular than town level? You just want your clinic's data to show the impact of your program. So thinking about that, what level of geography a data source is available at will help you pick it. If the data source is only available at a state level and you're a community health center wanting to track the impact of a CHW program on site, getting the change in diabetes rate of the whole state is not helpful to you. So that's one thing to consider. And this is very important because I think a lot of folks working in communities really need or want local data. State data isn't always appropriate for you. If you are a statewide organization who is really interested in very specific indicators, but you don't need it at a town level, so say you're a food advocacy organization for the whole state and you just want to know how many people in Massachusetts have access to healthy fruits and vegetables, then statewide data is great for you, right? But if you are a clinic or you are a municipality, you really want data for your particular area. And sometimes when you go to the Department of Public Health or another website, you see that your particular town might be suppressed. You'll see the phrase suppressed. And that just means that there's no data for that town. And I know that this is a huge problem across the state because there's a real thirst for more information at a town level. But the reason for that is because some data sources really were never intended to be at a town level. So if you get a data source like, say, hospitalization data, that's every hospitalization in all of Massachusetts. So it's pretty likely that there's going to be a bunch of hospitalizations in your town, right? A bunch of folks from your town are likely going to need medical care at some point in the year. But if you're looking at something like survey data, then that's going to be based on the population of the state. So this is a map of the population of Massachusetts. You can see that in the dark areas, there's a lot more people per square mile, but in those really pale areas, there's only between 90 and 3,600 people in those municipalities. So what we, when we design a survey, the number of people that are included in the survey often follow similar lines, right? If you randomly select 6,000 or 8,000 people in Massachusetts, you're probably going to see more people in those dark areas, and that's what we do see. So when you have limited resources for a survey, and surveys like the Behavioral Risk Factor Surveillance System, or BRFSS, they are really structured to tell you the most about the entire state as they can, while costing as little as possible. But there's only about 8,000 surveys that get distributed across the state. So if you're living in a small town that only has a thousand or a few thousand people, the odds that there's going to be a ton of surveys done in your one town are pretty low, right? If there's only 8,000 for the whole state, maybe 1 or 2 people in your town get a call to answer that survey. And what can you really tell from 1 or 2 people, right? If I asked just one person on this whole webinar what their favorite flavor of ice cream is, and I wanted to make a statement about every single person in the whole webinar, I'd probably be pretty far off. So that's why we're pretty reluctant to make broad statements generalizing everyone in a town when we may only have 1 or 2 data points in that town. So we aren't really able to say something with great confidence. So that's one of the reasons why town-level data is really hard to get, and that's also one of the reasons why you might see that suppression listed when you look at data sets. All right, so that's just a few aspects of geography that are relevant. So another aspect of data sources that you may want to consider when comparing and contrasting is who's in the sample population, who's in that data set. So sometimes this is directly related to the geography. In the case of surveys, for example, the surveys like the BRFSS or the school health surveys are designed specifically to ensure that they represent every single person in the state. So the way that they structure those 8,000 respondents is that they say, we want to make sure that we have enough, Asian women, African American men, people over 65, people under 65, so that we can say something meaningful about those folks across the whole state. Not all data sets have that level of specificity. Some data sets are just based on convenience. So when you hear the phrase convenience sample, that just means that whoever was willing to participate and whoever happened to be there was included in that data set. So for example, I don't know if any of your employers participate in the Walk Ride Day data collection, where they ask employees to submit data on whether they walked or rode their bike to work that day. That's a great program, but that's what they call a convenience sample. They aren't forcing every single employee to ensure that they submit data. It's just whoever's willing to talk about whether or not they walk or rode. So the folks who are more willing or more likely to report that data are probably people who are maybe a little different from the folks who didn't report the data. If you're a passionate bicyclist or a passionate physical activity person, maybe you're more likely to actually report it than someone who isn't as interested in those content areas. So that kind of data source is the convenience sample. Sometimes can be a little bit biased. You don't want to make the mistake of interpreting that to represent every single person in Massachusetts, when in fact it was just people who happened to volunteer that information. Other aspects of who's in the sample population could be things like looking at clinical data. When you are dealing with hospital discharge data or ER visits or even ambulatory data, so if people are getting access to healthcare in the primary care setting, that's very interesting and useful information about people who are using the healthcare system, But it doesn't tell you, for example, if you're looking at diabetes rates at community health centers, that doesn't tell you about everyone in the state because it's only people who have been in the healthcare system that year, right? So only folks who have somehow been touched by either a hospitalization or primary care utilization. So all the folks who don't go to the doctor, all the folks who just didn't schedule a visit that year, they're not in that data set. So again, you don't want to make the mistake of interpreting ER visit data, the number of diabetes-related ER visits, as being the same as how much diabetes there is in all of Massachusetts, because that's just a clinical population that you're getting. So when you're comparing and contrasting and picking data sources, that's another aspect of data considerations around the sample population. And we have a couple questions coming in, so I'm going to get to those when we get to the question section, because I'll try and incorporate them into my discussion moving forward as well. So another aspect of who's in the population is impacted by whether or not you're interested in certain subpopulations. So if you're interested in looking at people like me, so I'm Asian, I'm a woman, I'm under 65, so if you're really interested in a particular group of folks like that, you want to really consider how capable is your data set of giving you information about those people. So if you take a data set like clinical data, you're getting every single hospitalization in the whole state, you're probably likely going to get a large number of folks in a given subgroup, so you can say something meaningful about them. If, however, you're using survey data like the BRFSS, as we mentioned earlier, and there's only 8,000 surveys total, so you're probably fine if you want to just look at women, right? You've got roughly half of those 8,000 people are probably women. So you've definitely got enough to say something meaningful about women. But say then you want to talk about Asian women. Now you're like, that's going to be a small percent of that half. Now you're down to even fewer surveys. And then you want to look at Asian women in Rutland, Massachusetts. I can almost guarantee you that there will be so few data points that you will not be able to say something meaningful about that subpopulation. So maybe a survey isn't the best data source if you're interested in some of those smaller groups, because the likelihood of you having enough data points to really say something meaningful and reliable is pretty low. And that is basically what they talk about when they say sample size or power. Basically, if you only have a handful of folks who are part of a data set, how much you trust their information to speak to or be representative of everyone else in the population changes, right? If you're looking at 5,000 people and you're taking the average across all 5,000 Asian women, you're probably much more secure thinking that that's going to be representative of everyone in the whole state or everyone in your town than if you're talking to 2 people. So that is where issues of power and suppression can kind of be relevant to what data sources you pick and some of the challenges that you face with other data sources. So I think people do power calculations. We'll get to primary data collection in a little while, and I'll talk a little bit more about it then. But that's definitely an important consideration, and that's the terminology that's used when people talk about suppression at certain geographies. Now, when we get to the data sources themselves, I'll talk a little bit about some of the mathematical ways in which we try and overcome that, but there's limitations to how much we can wave our mathematical wands and make small amounts of data speak to a larger population and be reliable and be accurate. All right, so another aspect of data that you may want to consider when picking a data source is frequency. So this has a lot of different aspects. So the most obvious would be how often is the data released or how often is it collected, right? So if you are interested in just getting a really accurate estimate for your whole community for, say, a grant or a needs assessment, then maybe you're okay with data that's a couple years old, but it's really reliable and really tells you a lot of information about all the subpopulations you're interested in. So perhaps census data is fine for you because the census is really only done every 10 years. They do update it annually with what they call the American Community Survey, but the actual formal U.S. Census is only done every 10 years. So that's pretty infrequent. If you want to show the impact of your program over time, every 10 years is probably not going to be a quick enough interval for you. So maybe you want to turn to something that's released every year, like either the hospitalization data or some of the surveys we are going to talk about. But perhaps a clinic and you're doing PDSA cycles to show the impact of a community referral program that your CHWs are doing, maybe a year isn't enough time. Maybe you really need monthly or quarterly data. And so maybe in that scenario, you'd want to use something, if you're part of the Mass League of Community Health Centers and you're on CHIA drives, maybe you want to start getting some data extracts from that so that you can really show month to month, quarter to quarter, the impact of your program on just your patient population. So data release dates are very important in picking a data source. But time also has an impact when you're wanting to look at trends. So one of the ways that we get around the issues of geography, I mentioned before, say there's only like 20 people in your town who happen to be selected to take the Behavioral Risk Factor Surveillance Survey one year. How likely do you think those 20 people are to say something meaningful and really represent your whole town? You feel a little uncomfortable about that, right? Statistically, you're probably underpowered. You don't have a big enough sample size. But maybe if you take 3 or 4 years, now you're getting up to 60, 80 data points. So maybe you can say something more meaningful because you have way more data across many years. So in some of the data sources and data that we'll go over shortly, like MassChip and the Environmental Public Health Tracking System, we include what we call multi-year aggregates. So sometimes you'll see a 3-year average or a 5-year average, and that's why that's there a lot of times, is because there were so few people in 1 year, but that we couldn't really say anything about it meaningful, but if by combining 3 or 5 years of data, we're able to really give you some really important information, either about a certain geography or about a certain subpopulation. So I think we had a question about MassChip come up, and we're actually going to do a demo on kind of where to access MassChip data. For those of you who are unfamiliar with MassChip, it stands for the Massachusetts Community Health Information Profiles, and they basically have data reports at the smallest geography that is reliable. So in some cases that's town, in some cases that's community health network, in some cases that's county. And they actually have reports on a wide range of data topics. So I'll walk you through those shortly, but someone had asked how statistically significant we think the data like that is. And basically, we don't put the data out there if it doesn't meet our very stringent significance requirements. So when we have really small geographic areas for subpopulations, for example, say we're stratifying heart attacks by race, when we have that kind of data, we have a broad range of reportability requirements, including statistical significance, but not just that. There's more factors than just that that goes into our reporting requirements. And so if the data is very reliable, it'll be listed without any notes or caveats. But if the data is kind of, we're saying it's 75%, but it could really be anywhere between 68 and 78%, but we're pretty sure it's in that range, then there will be a little asterisk and a footnote specifying that you should interpret with caution, that this isn't as what we call stable. It's not as stable an estimate as some of the others. So there's different degrees of how reliable or accurate we think specific numbers are. And I actually used to have some slides in here about power and confidence intervals. I didn't want to overwhelm you with statistics speak, so I'm sure it would be great to have a more concrete, real data analysis webinar at a future date to go over that kind of info in further detail. Plenty to say on that topic, but I don't want to over-mathify people who may not be as interested. All right, so moving on. trends. Sometimes you'll see 3-year aggregates, sometimes you'll see 5-year aggregates. And why this is important to realize is if your program, say you're passing a complete streets policy in your town and you want to see the impact of that complete streets policy. If your data source uses 5-year aggregates, you're going to be waiting a long time to be really getting new data that really shows only your intervention period, right? So at baseline, you could certainly say, okay, here's the physical activity rates over the past 5 years before the grant. But if you have to wait for 5 more years to wait until you can say anything about physical activity for the 5 years after the grant, your stakeholders and your participants might be a little bit impatient. So looking at whether data is available for the populations you're interested in, for the geographies you're interested in the time frames you're interested in, is going to be really important in comparing and selecting different data sources. All right, so those are the aspects of data that, some of the aspects of data that are important when you're comparing data sources. So now I'm going to go through each of these specific types of data sources to tell you a little bit more about them and talk about how those aspects of data play out for each of them. All right. Now, I didn't insert a question slide here, but before we get too far down, are there any other questions regarding just aspects of data?
Well, someone asked here whether you'll provide a list of where to find data, which I know you'll be alluding to that later.
Yep. So I will definitely, I actually not only have a list in this PowerPoint, I'm going to walk through some examples of where to find the data, and I'm going to send out a handout, we're going to send out a handout with specific links, and I'll show you how that's structured in a little while.
We also have another question about how the Massachusetts CHIP information, how to determine whether the data is statistically significant, and how we measure data in a community that has much rental properties. So you could choose to answer that now or save it for the end.
So maybe we can talk about the rental property question a little bit later, like at the end, because that's a specific example. But I can take another second to talk a little bit about, actually, you know what, let's hold the mass CHIP statistically significant question until the end, because then I can pull up a mass CHIP report and then show you exactly how to tell if something's statistically significant. I'll do a live demo of that. So we'll save those 2 questions to the end, but good questions, team. Excellent thinking. Critical thinking. All right, so let's go through, again, all these different data sources and some of the pros and cons of each. So health surveys. As I said before, health surveys are intended to be representative often of the geographic areas that they represent. Some examples include the BRFSS, or the Behavioral Risk Factor Surveillance System, which is a national survey that's standardized through the CDC. Each state can include some special state-specific questions, but there's a set of questions that are consistent across the whole country, which allows you to compare how Massachusetts is doing to some other folks in other states across the country. Other comparable surveys include things like the Youth Health Survey or the Youth Behavioral Risk Survey or the American Community Survey. So all of these are very robust surveys that use what we call a weighted sampling method. That's what I referred to earlier, where they specifically ensure that key subgroups are included, so they just don't randomly take 8,000 people. They'll say, okay, we want 8,000 people, but we want to make sure that there's the same percentages of all the different subgroups as you would see across Massachusetts through the census data. So geographically, they're intended to represent the geography that they were designed for, and in the case of these, it's the state. Now, because there's all this great data, we do try and stretch that a little bit by using some predictive modeling and some mathematical approaches to combine the survey data with other data, like census data, to do some predictive modeling to try and give you guys a little bit more detailed data at a town or county level. And that process, you'll sometimes hear people talk about small area estimates. So that usually refers to a mathematically a mathematical prediction model in which we combine a few different data sources to try and predict what we think the rate is in a given town or county or zip code as we have power, statistical power to do. So sometimes, even though the BRFSS survey may not have captured or reported town-level data, or we don't have enough people in one town for 1 year to say something about it, we sometimes will combine other data sources and multiple years to use mathematics to predict what that rate might be. All right, the sample for health surveys includes a broad range of individuals, as I mentioned. They're intentionally structured so that all the key subpopulations are represented with regard to age, race, gender, so on and so forth. And surveys are, obviously different surveys are done at different intervals, but the BRFSS, the school health surveys, and the American Community Survey all are done every year, but sometimes they alternate what items are included. So in the case of the BRFSS, for example, there are certain items, certain concepts that are only included in odd years, and there are others that are only included in even years. So sometimes, even though there's a new release of the data, you might not see the thing that you're most interested in that particular year, such as fruit and vegetable consumption, for example. So when you're thinking about frequency, yes, it comes out annually, but you may want to consider exactly what indicators you're most interested in so that you make sure that it's available in the year you're wanting. All right, disease and injury registries. So these are very interesting. Some of you may be familiar with what a registry is. Basically, for certain conditions, it is required that physicians report every single case of that kind of disease or injury that exists. So that's not to say you're reporting individual people. I'm not going to say, oh, Sonori has a specific guy. It's just that you report that a case occurred, and sometimes there will be some other demographic and other important clinical information attached to that. So it's not a way of keeping track of individual people. It's a way of keeping track of if a certain group of folks might be suddenly experiencing a disease or an injury at a higher rate than others. And so the Mass Cancer Registry is an example. The Weapons-Related Injury Surveillance System is an example. The Bureau of Infectious Disease tracks a lot of different infectious diseases this way. It's how we make sure we're not getting certain outbreaks or epidemics. So again, we're required to report sexually transmitted diseases on that list. So when you have data from a disease or injury registry, you know you're getting every single person who has experienced that condition. However, obviously, if someone's hiding it or doesn't know they have it, they obviously wouldn't be part of that data set, but it would be all diagnosed conditions by physicians. So again, the geography, this covers all of Massachusetts. It actually covers many different states because these registries exist nationally in many instances. Sample, again, they include every single person who they should include every single person who has been diagnosed or who is in treatment for that condition. Frequency, the data gets updated to these registries throughout the year in real time, and they release data reports, usually on an annual basis. And data requests for different time periods can be submitted if you're interested in some other way of slicing and dicing the data. All right, so that's disease registries. So clinical data and hospitalizations. Now, I mentioned this in passing, but there's really three major categories of clinical data that folks will see. So one is claims data. So this is anytime your insurance company is billed for something. That includes medications, that includes devices, if you get like a free blood pressure cuff, or if they cover a blood pressure cuff, or but it also includes actual billed services at hospitals, etc. So the claims data, because it really comes from a billing world, only includes certain kinds of fields and pieces of information because billing people may not care about some of the nitty-gritty details of physician notes or something like that. So you have to be aware of those limitations, but it is representative of all claims across the state for now. So that data set could be coming from an individual insurer. You know, I know a lot of insurers do a lot of great work with their claims data, but there's one central repository called the All Payers Claims Database that organizations can request to get access to. You can submit an application to CHIA, the Center for Health Information and Analytics, to get access to that. And if you have academic partners, many of them may already have access. Some of you, if you're in the data world, may know that there was a landmark court case this past year. It went to the Supreme Court, and there are some questions about the future of the All Payers Claims Database. At present, everyone is required to include their insurance claims in that large data set. Moving forward, it might become voluntary. We're not sure how useful it will be if insurers can choose whether or not they submit it. All right, so that's claims data. Administrative and discharge data. You may hear this referred to as the case mix data set. Sometimes you'll see it referred to as hospitalization data. Sometimes you'll hear it referred to as ER data. This is discharge data. Every patient that comes in and goes out of a hospital or emergency room gets included in this data set. In terms of sample, it is every single person who enters into or out of a hospital. Again, this only includes hospitalizations and ER visits, so this does not tell you anything about people who just went into their PCP for a vaccination or had a cold. So this only includes severe hospitalizations and ER visits. It is, again, for the whole entire state, and there are updates. It comes out every year, and then generally we at the Department of Public Health analyze it and include it in a number of different reports that we have. Finally, we have electronic health record data, and again, this comes in many different forms. If you are part of a clinical organization, you probably could get access to your own EHR data. In the case of community health centers and those who are part of CHIA Drives, which is a data platform run by the League of Community Health Centers, you actually have some increased capacity to analyze your own electronic medical record data. If you're not a clinical organization, you can actually reach out to your local community health center to see if they do have that capacity as well. And electronic health record data includes much more than claims or administrative in some aspects. It would include all the different physician-related fields, diagnostic fields, things like that, as well as information on ambulatory care. Oh, something transpired. Not sure. Sorry, give us a quick second. Just gonna kick off. There we go. Anyway, sorry about that. Okay, so EHR data is very robust. It's also the area from which we can learn about ambulatory care or outpatient care. So if you're going to your local primary care physician, this is where we get information on a lot of kind of maintenance and preventative care as well. There's a data source that you may have heard about called MDPHnet, from which we get some of this information. That is a collaboration across multiple different systems, including the Mass League of Community Health Centers, Atrius Health, and Cambridge Health Alliance. And they've been able to pool this ambulatory data, this outpatient data, to start giving us some really great information around preventative care and primary care. So in our reports, again, I'm going to walk you through MassChip and a few others shortly. If you see some of that data, if you ever see MDPHnet data in a presentation, you know that's kind of where it's from. Okay, so geography covers everything. Sample covers everyone who's in the health system. None of these data sets are going to tell you anything about folks who are who didn't go to the doctor or who don't have insurance and aren't seeking care for anything, or people like my husband who haven't been in to see a physician for 5 years, even though he is one. But so those people are left out of this data set entirely, so be aware of its limitations.
A quick question here about, can you please define the acronyms? I'm not sure what they stand for. I believe it's what currently is on the slide.
Oh, okay, sorry. ER is emergency room data, And electronic health records is what the EHR stands for. Sometimes you'll see people call it electronic medical records, EMR. We've moved away from that description because we really think that health goes beyond medicine, and your health and wellness should be beyond just whether or not you're in medical care. So I apologize for that. Normally I try to be good about defining things. So ER is in fact emergency room. Okay. So another source of health data that we had in our overall slide is count or census data. So this is a situation where every single person, period, is included in the data set. So not just every single person who went to the hospital or every single person that was included in that survey. This is every person. So birth data, if you're born, you have a birth certificate. If you die, you have a death certificate in Massachusetts. Obviously, if you were in another country, that data wouldn't be in our data set. The U.S. Census is intended, again, to be a count and representative of every single person in the United States. Whether, yeah, the approaches vary a little bit. So these data sources are useful for a number of reasons. Another example could be, well, we'll just stick with these. So geography, again, everyone in the state. It's also great because you can get very granular. You can get data for a specific town. The sample, again, includes everyone. Some of the limitations are that there's only so many data fields included. Again, whenever you use a data source, you have to think, why was it originally created? Because most of the time, we're using it for a reason other than what it was created for. The exception being health surveys. Those were literally created to give us information about health from the entire state. So birth records have great data about the mother. It has some information about demographics, but it may not give you that really nuanced information about some of the more detailed health aspects that you might be interested in. Frequency, they are collected continuously over time and again released at specific intervals throughout the year. So you don't have to wait, whereas U.S. Census is every 10 years. And again, as I mentioned before, they do have a survey, a subsample called the American Community Survey that's done every year. All right, before we transition, I'm going to cover a few other types of data sources that might be relevant to you at a local level. If you're in a town where you have some clinical trials going on, sometimes your academic partners might have some studies going on, that might be a source of data for your particular town that wouldn't be available for everyone. Some examples would be the Women's Health Initiative study, the Framingham Heart Study. That was some really detailed data in a very specific geographic area. Other data sources could be capturing environmental data. The Bureau of Environmental Health has a lot of phenomenal data out there on air particulate matter and lead poisoning and water contaminants and beach water levels and, well, actually the EPA might do that, but as well as proximity to highways, things like that that are environmental in nature. Transportation data sources include the Massachusetts Department of Transportation, or MassDOT. They do a Massachusetts travel survey where they look at different types of physical activity metrics. There's also transportation data at a municipal level. Perhaps your regional planning agency or your planner's office might do regular bike and pedestrian counts in your town. A lot of times they also incorporate and use a lot of census data and demographic information. Other sources of data include things like emergency services, so EMS or emergency medical service calls, so that's anytime you call 911. Police logs, the Sheriff's Department keeps data on the actual police records. Other services by other departments include things like the Department of Transitional Assistance and the Department of Children and Families, also the Department of Elementary and Secondary Education. All of these folks that provide actual services often have data reports up on their websites as well, and will also sometimes fulfill data requests as well. So while these aren't direct clinical care, health behavior services, they are data sources that we sometimes tap into when we're doing health outcomes research. All right, so now we've talked a lot about all the different aspects of different data sources that we sometimes weigh and compare when picking between them all. And I just wanted to give you a quick reminder that you really want to remember your audience, right? So when you're, not only do you want to consider all those different factors that we just went over, but you want to say, okay, am I writing a grant? If you're writing a grant, then you really want to establish need, right? You want to establish burden and need in your community. So it's probably fine if you include 3-year aggregates that are really accurate for your community, because what you want to show is Worcester has this need or Springfield has this need. You don't need to say in 2013 versus 2014, right? So maybe an aggregate number is more appropriate for you because geography is more important to you and overall burden is important to you. But if you're doing quality improvement or quality assessment, then getting a general number for Worcester is not that helpful for you unless you're working in all of Worcester. So maybe for you, getting access to that very specific clinic population and getting really time-specific data is important, right? Maybe you need quarterly data. Maybe you need monthly data. So maybe going to Chia Drives, working with the league, and getting a data extract from them is really going to give you that timely data pre-post to capture how effective your program implementation has been. If you're trying to decide where to spend money, maybe you want to do some data-driven resource allocation. Maybe you have enough money to set up 5 diabetes prevention programs, and you're wondering, where do I put them? So again, maybe what you want to look at is cost and burden. Maybe you want to say, okay, I want to look at how many hospitalizations are there across the state for diabetes. We really want to attack that issue and look at where it's concentrated. So you really want the granularity of knowing what the concentration is in different towns. So these kinds of audiences are going to really drive what aspects of the data you pick for the different purposes you want to use it. But sometimes the data doesn't exist. So as much as we try to collect and provide as much data as we can at the state, there's just only so many types of indicators or metrics or performance measures that we really can capture, and there's only so many different ways we can slice and dice it to say how they relate to specific subpopulations. So 2 ways that you can collect your own data when the existing secondary data, that's what we call it when you're using data that was collected for a different purpose. So if secondary data doesn't exist, sometimes you have to do primary data collection. And you can do it in 2 ways, qualitative or quantitative. And you've probably heard those phrases. Some of you probably know what it means. But qualitative is very open-ended. There's no formal answer choices. You can, some of the approaches for collecting qualitative data is doing things like focus groups or key informant interviews, where you can say something like, okay, what were the biggest barriers to implementing your EBT machines at your farmers markets? Or what were the biggest barriers to getting a CHW program up and running? And it's open-ended. Quantitative data means there's set answer categories for the same kinds of questions. So you could get quantitative data from surveys, administrative records, program tracking sheets. It means there's a specific set of answer options. So for example, a quantitative approach to the same concept would be, which of the following barriers did your organization experience when implementing a CHW program? And then everybody gets the same 10 that they can check off, and then you see which ones were most commonly endorsed. So anytime you're doing quantitative data or qualitative data, you want to engage with folks who are experts in that area to make sure you're doing it in a valid way, to make sure that you have power. You're not just asking 3 people and then generalizing for your whole town. To make sure that you're picking the right folks, that you're not just only picking people at a clinic when you really want to know about everyone in your whole community. So engaging with some important, with other folks is going to be helpful. So who can you engage with? Who can help you make sure that either doing your primary data collection in the most statistically valid and methodologically valid way possible, and also who can help you with really wrestling with all these secondary data sources and analyzing it. So academic organizations are great collaborators. A lot of times they have students who are interested in doing projects. A lot of times it can be a mutually beneficial relationship to reach out to academic organizations who may be doing work in your content area already, who may already have data on your particular area of interest. Regional planning agencies, so these are groups of planners throughout the state. Every single part of Massachusetts has an RPA, or a regional planning agency, and they help with infrastructure decisions. They do a ton of mapping. They digest and map out a lot of the census data right away. They do counts, and they're a wonderful resource and partner around the built environment. Community-based organizations often collect their own data. Hospitals, especially people involved in the community benefits world, often have applications that they're writing regularly, so they often have actually collected and written up data on the need in their particular region for their applications every so many years. Consulting firms, so there's a lot of agencies. If you want to just hire staff who are experts at evaluation, you can reach out to a group like John Snow International or Mathematica or RAND or RTI, and just pay them to have someone come on board and be your evaluation or statistics consultant. And local boards of health. I know a lot of the bigger cities throughout the state already collect and digest a lot of information at a local level. So these are just a few of the entities you can reach out to so that you're not just trying to be a jack of all trades. There's a lot of them may have already done some of this work, and you might be able to leverage that instead of reinventing the wheel. All right, so that was a lot. That's all the data. That's a description of some of the aspects of the data that are out there, and kind of a listing out of what we should consider when picking what kinds of indicators to use. In the interest of time, I'm actually going to just walk through a quick demo of the handout that's going to be released, and then we'll just go through all the questions, because I think there's some really good questions that have been coming in. All right, so I think you will be receiving these handouts, and there will be two sides to the handouts. So for those of you that attended OUNCE, this is an updated version of that. OUNCE of Prevention is a conference that is held annually. So this is a list of specific health data sources, and they are ordered from the most easy and quick to digest all the way down to the most detailed. So detailed means you can literally download the data and analyze it yourself. So that's Medicare, Medicaid has some really detailed data, as does the Census Bureau and Fact Finder, and I know a few of you already mentioned it in your questions and comments. But at the very top, you have the National Environmental Public Health Tracking System, where you don't get to customize what you get, but it's a really quick, easy to digest, easy to see or identify data source. So this is what the National Environmental Public Health Tracking webpage looks like. You can enter a zip code, 2108, let's just pick Boston because that's where we are, and it pulls up a really great digestible infographic giving you a quick overview of demographics, and all of this is dynamic. You can click on any of this to get more information, as you can see. But it also, as you scroll through, gives you information on some of the key health conditions of interest, things like asthma, air quality, particulate matter, smoking rates, heat incidents, heart attacks, access to parks, proximity to highways. So this is a broad range of health indicators to just show how folks are doing and what they have in their communities. So you don't get to pick what you get, but it is really easy to get a quick overview of your particular community. So that's the most easy and most quick to digest. So another example would be the Mass Environmental Public Health Tracking System, and you're going to have an entire webinar available on how to maximize this. So I'm not going to go into it in great detail, but I did want to just show you that there are a number of different data content areas listed here that you can get data on, and when you click them, you not only get a quick overview of the condition itself, you can scroll through and see some broad overview data, but you can also do a live query to figure out, I pulled this up already so that we wouldn't have to redo it. Yeah, so you can live query to click what you're interested in, what conditions you're interested in, what regions you're interested in. So you can say, okay, I'm only interested in Massachusetts, or I'm interested in a specific community, and then it'll let you select which towns or communities you're interested in. So here you can scroll through and pick your town, what years, etc. So you'll get a full demo on this, I believe, coming up in a couple months. But in the interim, if you want to play around with this, this will provide the data with a mapping interface where you can zoom in on your particular region. All right. And then we had a few questions about MassChip. So MassChip is the Massachusetts Community Health Information Profiles, and they are actual reports, again, organized by content area, as you can see here. And then you can click that particular content area and you get a couple of different data sources that you can pick. And once you pick one of those, it gives you specific reports by town or by region. There's a bunch of different geographic regions that they have this information by county. So, for example, say we're interested in Boston. That data report gets downloaded, and you can open it right up and take a look at that particular health condition for that particular town. So this is where some of those questions around significance, statistical significance, might be relevant. As you scroll through the MassChip report, you can see that it's separated out by different subgroups. So you can see males and females. You can see different age and race categories. And to address the question about statistical significance, none of these fields would be filled if they did not meet our reportability criteria. So here you can see we've got a couple of different types of diseases split out by race. And in some of these, you can see it says not applicable. So that means that we were not able to report on that particular subgroup. So we wouldn't even put it in this table if it didn't meet strict reportability criteria for us. So another thing that you may want to take a look at is, and I'm just going to scroll through here to get to one of the tables that has confidence intervals. Oh, for some reason I'm not seeing confidence intervals on this one. Oh, here we go. So, so here's some data on risk factors. So sometimes you'll see in parentheses in a table what they call a confidence interval. So that means here's a number that came out of our mathematical calculations, 15%. But that number really is somewhere between, we think we're 95% confident that that number falls somewhere between 14 and 17. So don't put all your money on it being exactly 15.8. We expect there to be some variability year to year, and we're pretty sure it falls in this range. So if you're looking for statistical significance, what you look for is whether or not these confidence intervals overlap. So, for example, former smokers, is Boston different from the state, right? So you look here, you see that Boston is somewhere between 20 and 23, and we're pretty sure that the state is somewhere between 28 and 29. So there's a big difference between 23 and 28. So we're like, even if it's the worst case scenario and Boston's actually closer to 23 and the state's closer to 28, those aren't anywhere near each other. So we say that we think that Boston is statistically significantly different from the state. So that's as mathy as I'm going to get. There are plenty of resources available to help you compare. But anytime you're looking at all these tables and all these reports and you want to say, okay, are these two cells different? Then that's how you would compare them. All right. So those are the data sources that you'll be getting. And there's another whole page of data inventories, which actually gives you long lists of data sources that you can use to sort through all the different data sources that are out there. You will be receiving these as a handout, but we're going to open up for questions and answers. I think folks have been submitting really great questions throughout, so go ahead and type it in if you have one now. All right, so the first question is, Will we be able to provide us a list of where to find data? So yes. So as you can see, we have these two handouts where not only do we have a list of actual links to data sources and inventories that also organize data sources, but we also have a number of different criteria to the right, including what level of granularity, state versus local versus county, those data sources are available at. All right, and we also had a question about statistical significance, so I tried to weave that into the mass chip piece. Anytime you see a confidence interval range, you want to look for whether or not those ranges overlap, and if the numbers don't overlap at all, then you can say that those two different cells differ and are statistically significant in their difference. Another question that just came in is how do we measure data in a community that has more rental property and therefore a transient population? That's a great question. So that's where temporal aspects come into play. There are actually some factors. The concept you're referring to is what we call flux. So in the census, there's actually a question about whether folks have lived in that area for a certain period of time. So that's a metric that we use to identify whether we think that the same people tend to stay in that area or whether that's an area that they have new folks coming and going all the time. So using that metric is one way to find out whether your neighborhood is like that or not. But the other aspect is that you really want to be cognizant of when the data is collected and released. So this is a situation where multi-year estimates are probably less useful for you. So maybe you want to pick a data set that is either released every year or more frequently so that you can really capture the folks who are being impacted by your intervention at that moment in time. This may also be a situation where secondary data sources have limitations. You know, there's a number of studies going on right now trying to look at gentrification, and we tried looking at secondary data sources to see how we can keep a hold of one person over time. And there's a lot of limitations around that. So they are actually, they had to resort to primary data collection to complement some of these secondary data sources to actually try and get emails and phone numbers from folks so that if they moved to another town, they could keep track of that individual person. That being said, the hospitalization data is linked to individual people. So you can't look up anyone's name, address, or like any social security number. You can't look up any of that information, but you can tell for an anonymous, unknown person in time in the claims data all the different medications they filled, doctor's appointments that were paid for, things like that. So the clinical data is not restricted to a specific geography. So if you have residents who move, then you can still track them in time to some degree that way. All right, next question. What are the best ways or tools to prioritize data and visually present data to stakeholders and community health partners to keep them focused, goal-oriented, and action-based? Well, that's a pretty broad one. I always think that graphic visualization of data is really impactful, and certainly trends and pre-post is a really great way to show your stakeholders progress. We use a lot of statistical analysis software, and if you partner with different folks like academic institutions or consultants or even a regional planning agency, they might be able to help you with creating a map or some of those graphics. However, some of the data sources on this list, so for example, the Massachusetts Environmental Public Health Tracking System and the national one, they actually generate maps for you, so you can take a screenshot of that and use that for your stakeholders as well. But you're right, Excel alone does not have all the functions you might like, so I'd suggest reaching out to some of your partners for that. All right. What are some software programs available for partners to collect and share data for grant work being done aside from Excel spreadsheets? If you're talking about actual data, then there's a number of different database building programs out there. If you're doing a survey, you can use something like Checkbox or SurveyMonkey. If you want to get more advanced, there are things. Adobe has a number of different programs out there, Adobe Connect, Adobe Pro, Adobe Lifecycle, that allows you to have different people at different locations enter data that goes into one central location. There's programs like RedCap and Access. That might be more technical. I think some of the parameters to actually get those up and running requires a lot of expertise. So that may be another area where you want to reach out to some local partners to help you build a database. Honestly, students really love that work. It's a great learning experience. We partnered with a number of nutrition students to be involved in some of our healthy retail work. They're really passionate, really smart kids who, it's a great learning experience for them. It's a great learning, a great benefit for us as well. So for work plans, there are additional programs such as SharePoint, things like that, where you can share similar tabular types of data between individuals. So SharePoint specifically works with Office 360, which is a cloud-based version, so that you're not each, so you have version control with Excel. All right, any data source recommendations for poverty or food instability on a town or county level? So there's actually food access scores that are comparable to, you may have heard of walk scores. So we can send this around after the fact, the link for that, but it is a similar program where they take a look at what types of retail facilities, restaurants, etc. exist in a given region, and they generate a food access score for a particular geography. So I think that would be a really great one. The BRFSS, depending on the geography you're most interested in, is another data source around food access. So they capture things like fruit and vegetable consumption. Another less commonly used data source that's not really directly health but is related to what you just asked about are sales data. So things like Nielsen sales data, InfoUSA, things like that, they actually come from the marketing world, but they collect a lot of information on purchase and sales. ESRI, ESRI plugs into the mapping software for this as well, and you can actually get data reports on market penetration of certain kinds of food access folks, things like that, and then compare that to the poverty rates and environmental justice regions if you want to go a little bit beyond just poverty to talk about socioeconomic status. So those would be some of the resources that I suggest if you're really interested in food access and availability. All right. Another question. I need to know if a population has lived in poverty for the past 30 years as measured by the 2000 decennial and 1990 decennial censuses and the most recent small area income and poverty estimates. I have not been able to get this data easily, especially the bicentennial data. Are you familiar with this data set? Yes, so I am familiar with the data set. So Census actually releases their data you can actually download it and analyze it yourself, but you're right, in the prepackaged reports that they have up on their website, it is a little bit harder to find. So two options that I would suggest is, one, definitely reach out to your regional planning agency, because a lot of times they already have this data built in and they've probably already mapped this for your region. So no need to reinvent that wheel. If that is not something that you either can or are able to do, then another option is actually to use ArcGIS. ArcGIS is a software program for mapping, and it is a little bit more technical to use. So if you partner with a consulting agency or an academic agency or an RPA, they definitely can help you with this, but it has census data built in, so you can actually select what year census you want and what variables you want, and it's already built in. So I'm not even suggesting that you go to Census and download this yourself and try and figure it out. Those are two way easier approaches to really get at some of that poverty data at different years, and then combining different years as well. All right, so that seems like the end of the questions. Thank you for phenomenal questions. Excellent interactivity, team. One of the better webinars. All right, Davey, I'll turn it over to you.
And thank you so much, Sonori, and really wonderful presentation. I've learned so much. I'm sure others have as well. I echo wonderful questions. Feel free to keep sending those in. We can definitely follow up if there's any additional ones. And again, here are examples of some of the sites that Sonori has included in the presentation, and we'll follow up and send an email with the link to the recording of the webinar, a PDF of the actual presentation, and also any other resources that have been mentioned since then. But feel free to connect with us. I'll share our contact info in a bit. I cannot thank you enough for such a wonderful presentation, and really, I think, easy to digest and understand a world that may not be very comfortable for some people. So data. Just to give us a heads up about what's coming up. So again, this webinar is provided by for free. Thank you to the Massachusetts Department of Public Health for funds to help us to do that. We have some upcoming trainings and webinars that can continue to help you do your work better. Some that we have highlighted here that are scheduled is how to identify multi-sector partners, and actually Sonori alluded to some of those already. And this is a webinar to help you identify who those organizations could be and how to get them at the table. We also have an in-person training in the Berkshires area at the end of November, coalition capacity and infrastructure training and sustainability and resource planning to continue to add more tools. Sonori also alluded to the Massachusetts Environmental Tracking website. We're going to do a pre-recorded guided webinar for that sometime in the spring to walk you through all of the wonderful information that's included in that website. So all that info can be found on our website, hrainstitute.org, as well as you can email us at HRIA. That email is listed there. Our Twitter, and some of you have been sending us message to Twitter, so we really appreciate that. We're also on LinkedIn, and again, there goes the number that you can text to be added to our email list so that you could be the first to hear this information. We also have the wonderful Sonori Armstrong present today, and her email is included if you have any follow-up questions. And we would just like to thank you for your wonderful questions and thoughtful comments this morning, and we hope you have a good day.
Absolutely.
Awesome.
Thanks, everyone.
Thank you.